Hello, my name is Rebecca Overton. I'm a practicing GP and I'd like to welcome you all to today's Health Ed podcast. Today I'll be speaking to clinical haematologist Dr Nicholas Weber about myeloma. In our previous podcast, we discussed the biology of myeloma, the epidemiology, clinical features, investigations to do and when to refer. And today we shall be talking about initial and maintenance therapy, treatment complications, ongoing monitoring, vaccinations and survivorship. Dr Nick Weber is a haematologist at the Royal Brisbane and Women's Hospital and senior clinical lecturer at the University of Queensland. He has a clinical interest in plasma cell disorders and is involved as a clinical investigator in a number of research activities in this disease group. In his role as chair of the education pillar of the Medical and Scientific Advisory Group for Myeloma Australia, Nick advocates for education to raise awareness and promote empowered decision-making for patients and families living with myeloma. So Nick, welcome, and thank you for joining me once again for today's Health Ed podcast. Why don't we get you to start by telling us again a little more about yourself?
Thanks, Rebecca. Thanks for having me back. Yes, my interest in myeloma education really stems from a lot of feedback that I get from patients, particularly who have great relationships with their GPs, but when they're diagnosed with myeloma, often find that their GP is not particularly familiar with the disease and the complexity of management. So I think I get a lot of feedback from GPs as well, saying, how can we help? What can we do to support the patient? And because the field is changing so rapidly and there's so many new developments, I think we really need to bring our GP colleagues along with that journey to help support the patients as much as possible.
This is the Clinical Takeaway podcast from Health Ed, where we interview leading medical experts on important topics that can positively change the way you practice.
I thought I'd provide a quick recap for our listeners from the sort of things that we covered in part one of this series, where we talked about the biology of myeloma and epidemiology. So it's a plasma cell dyscrasia. There's a production of an abnormal immunoglobulin, which is called a monoclonal protein, which has heavy and light chains, or sometimes just light chains. And it can start as MGUS and then become a smoldering myeloma and then may progress to myeloma. And it's important to understand that everyone who has myeloma once had MGUS, but not all people with MGUS will go on to develop myeloma. And myeloma is defined by events under the CRAB criteria, so that's raised calcium, renal impairment, anemia, and the bony lytic disease. And you told us last time that there's about 2,500 new cases per year in Australia, most often seen in people in their 60s and their 70s, and a prevalence of about 20,000 Australians who would be living with myeloma. And what's exciting is that we're seeing improved life expectancy with a median survival across all age groups of about 6 or 7 years. And we want to try and diagnose this condition early and refer early so that we can avoid irreversible organ damage and functional impairment. And what's very exciting is the expanding range of therapies. So there's real optimism around therapy in this disease, and you'll be sharing that with us today. So why don't we start by talking about the key components of initial myeloma therapies that GPs need to understand? What does sort of induction chemo, for example, look like? What are the agents involved?
That's right. So I guess just a few key points to summarize the treatment philosophy with myeloma. With our currently available therapies, we really don't think at this point that we can cure the disease. We can't eradicate it completely. So the goal of therapy is really to try and induce a remission and reduce the disease level to the lowest possible range, and then maintain that response for as long as possible to keep people free from disease complications like the CRAB features that you mentioned. So for upfront therapy in newly diagnosed patients, the treatment is pretty standardized. The recipe is fairly pretty much the same across the country. And in all cases, whilst we do consider individual patient factors like frailty and organ function and geography and patient preference, our selection of induction agents is pretty much standardized. We tend to use combinations of drugs rather than single agents, and usually in conjunction with dexamethasone, which is a very powerful anti-myeloma agent. And the therapies have really, the paradigm has really changed from, treating the disease when it's active and then giving patients a treatment-free period to continuous therapy to try and maintain pressure on the myeloma and prevent it from progressing. So prolonged treatment over many years is now essentially the reality for patients. We do often need to dose modify and adjust our therapy in response to toxicity and side effects. And that's fine. We always prefer to patients to be on something, even at low doses, rather than nothing at all. So identifying toxicity early and adapting therapy in response to that is really important. And so I think the role for GPs is encouraging and helping patients maintain adherence to their treatment, but also supporting their quality of life, which we'll talk about later, as well as the day-to-day stuff, preventative healthcare and management of comorbidities, particularly diabetes, which often becomes an issue when we've got patients on prolonged steroids. So you did mention induction and I guess the stages of therapy for newly diagnosed patients. Initially, we have the induction phase. Now, that is usually a combination of 3 drugs. The first is bortezomib, which is a subcutaneous therapy. It's called a proteasome inhibitor. It has a mechanism of action that's quite different from our standard cytotoxic chemotherapy. We use bortezomib in conjunction with lenalidomide, which is an oral tablet. And in fact, it's a derivative of thalidomide, which was, as all your listeners will know, has a very dark history. But lenalidomide and indeed thalidomide have quite potent anti-myeloma activity. So these drugs are used very widely. We use that in combination with dexamethasone, as I mentioned, because dexamethasone has direct cytotoxic effects on myeloma cells. And in some cases, we'll also combine that triplet combination with a newer agent called daratumumab. And daratumumab is a monoclonal antibody that's given also as an injection under the skin. So this combination of drugs we use repeatedly over several months to induce disease control and try and achieve the deepest level of response that we can. After induction therapy, we then make a decision about transplantation. And transplantation, it's a therapy that's been around for many decades, so it's very familiar. It's basically a method of giving high-dose myeloablative chemotherapy to try and reduce myeloma burden further. And then we use the patient's stem cells, which we've collected and stored in advance, to salvage the bone marrow, to repopulate and regenerate the bone marrow after the chemotherapy. And transplantation is used routinely in Australia as part of upfront therapy, but only in patients who are deemed eligible based on age and comorbidity. So some of our older patients or those with a lot more frailty or comorbidity will often not be offered a stem cell transplant. Once we've completed that induction and or transplant phase, we then move on to the maintenance phase of treatment, which is usually oral low-dose lenalidomide given continuously until the disease progresses or until patients experience side effects that mean we have to stop.
What sort of treatment side effects should we be aware of as GPs that patients might mention or we should be asking about from the induction part of the chemo protocol and also the maintenance phase?
I think the toxicity of these agents is really predictable. And I usually say to patients, look, you'll experience something. The key is to identify it early so we can adapt our therapy in response. So bortezomib is well known for causing peripheral neuropathy, which is a complication that's common to lots of other anti-cancer therapies as well. Usually beginning with altered sensation in the soles of the feet, the fingertips, sometimes icy cold feeling or restless legs, then progressing to numbness, sometimes paresthesia. You can see burning or experience burning discomfort of the soles and the fingertips. And left unrecognized, it can progress to cause gait disturbance and motor dysfunction as well. So peripheral neuropathy is a key one. With lenalidomide, patients can often experience rash, often an itchy rash with initiation of therapy. In patients that have been on treatment for longer periods, we can see cramps, diarrhea, and there is an increased risk of venous thrombosis and probably arterial thrombosis as well. And so we make sure that patients are taking some form of thromboprophylaxis while they're on lenalidomide. Probably the biggest issue is the dexamethasone because we use pretty high doses. Patients can be on up to 40 milligrams once a week. And dexamethasone given repeatedly over many weeks to months, we know has a lot of metabolic side effects, neuropsychiatric side effects, insomnia, personality change, moodiness, which can really affect the patient's carers and family members just as much as the patients themselves, coupled with high blood sugars, weight gain, hypertension, all the steroid side effects that we think about. It's often dexamethasone that patients struggle with the most, and we often need to dose reduce for that or for those side effects as well.
Can I just take a step back with the venous and arterial thrombosis that you mentioned with the lenalidomide? What would prophylaxis look like for that?
Yeah, so the risk changes depending on what drugs you're using in combination with the lenalidomide, what the dose is, and how far or how long you've been on the treatment. But really, everybody that's on lenalidomide should have at least had an assessment of risk and should be on some form of prophylaxis. In most cases, we're comfortable using low-dose aspirin. But in patients that have additional risk factors, such as a previous history of thrombotic disease, a strong family history, we will then recommend either a DOAC, like apixaban or rivaroxaban, or in some cases, Clexane. And so that decision really gets made at the beginning of therapy. And depending on how patients tolerate that thromboprophylaxis, we'll try and continue them on it as long as they're on lenalidomide.
And you mentioned that treatment tends to be fairly continuous now as you go from induction into maintenance rather than having pauses in treatment. So is there a cumulative risk of toxicity with these agents that might then limit patients being able to continue to tolerate treatment or need to have a break from therapy?
Yes, so neuropathy obviously can occur cumulatively, and patients who are on bortezomib for long periods of time will inevitably develop some neuropathy. But really, the lenalidomide is probably the agent that people are exposed to for the longest period of time. And we know that diarrhea can be a late effect. It can happen up to 12 months after starting treatment. So new onset diarrhea in a patient on lenalidomide, we're very skeptical about other causes. It's almost certainly going to be lenalidomide. And there are things we can do to address that to maintain patients on treatment. The other thing that's emerged and is something that's been observed for many years now is the slightly higher risk of secondary cancers in patients taking lenalidomide. And so this is a side effect that we're very wary of, and that we really need GP help in surveillance for secondary cancers, because the risk is probably affected by what other therapies the patient's been exposed to. But there's definitely a signal that the risk of patients developing secondary cancers is higher than the population of patients not taking lenalidomide.
And so what are the important sort of surveillance monitoring that GPs should be thinking about? Is it the usual things we would do, like regular skin checks, mammograms, PSAs,
Right.
bowel screening, that sort of thing? Is there anything additional we should be considering?
Right. No, look, I think it's really skin in Australia is one of the biggest things. So encouraging regular skin checks, and we don't recommend cancer screening outside of the current guidelines, depending on age and risk factors. So bowel, breast, skin, and we also screen obviously for blood cancers, because leukemias can occur in patients taking lenalidomide, just with full blood count checks while they're on treatment.
And what about sort of vaccination recommendations then? These are patients who are receiving ongoing sort of therapy, some of which is cytotoxic. So what should GPs know about vaccination, prophylaxis and ongoing vaccine recommendations?
Yeah, but this is a really important point, because infection risk is something that patients are often very wary about. And we tend to give this blanket advice in oncology about your immune system is reduced, you're at risk of infection. And some patients interpret that very seriously and restrict their activities, ban visitors, stop what they're doing in their daily lives, and are very concerned about infection risk. And in fact, the risk of infection varies with what treatment you're taking, what time point in your disease, you're seeing your patient. But there are some things that we can do across the whole population to reduce risk generally. And vaccination is a really important part of that. So in general, we are fine for patients to receive inactivated vaccines, but live vaccines like MMR and the old shingles vaccine, the Zostavax, and any other live vaccines that may be recommended are generally avoided, particularly in patients that have had a stem cell transplant. So as a general rule, we discourage live vaccines. In terms of regular age-appropriate vaccination, we follow the immunisation handbook. So we like to make sure that patients are up to date with their influenza vaccinations once a year, COVID-19 vaccinations, which are 6 to 12 monthly. The pneumococcal vaccination is really encouraged. And so the current guidance is for a conjugate vaccine, which is a Prevnar or similar. and then a year later, a polyvalent polysaccharide vaccine, or Pneumovax, and then a second dose 5 years after that. So we just like to make sure that patients are up to date, and having access to the immunisation register is really helpful in ensuring that if you haven't seen a patient before and you're not sure what their history is. And then the final vaccine that I think is really important is Shingrix, which is the inactivated zoster vaccine. And we recommend 2 doses at least a month apart, and that is available to patients with immunocompromise on the National Immunisation Program. So I like to make sure that those 4 are up to date. And then in the proportion of patients that are receiving a stem cell transplant, the transplant centre will actually organise for a course of booster vaccinations after the transplant, usually 6 months after transplant. And that's because patients can lose a lot of their latent immunity to childhood vaccination from the transplant. So the transplant centre will be organising Haemophilus, pertussis, diphtheria, tetanus, hepatitis B, polio, meningococcus, those what we assume everyone's had in childhood. The hospital will generally organise those booster vaccinations so the GP doesn't have to.
And you did mention the sort of routine vaccines that we'd be familiar with: flu, COVID, Prevnar, pneumococcal and Shingrix. What about for adult patients that may not have had meningococcal vaccination for ACWY or B? Should we routinely be offering that even if they haven't had a transplant?
Yes, I think that's important. We don't see a lot of invasive meningococcal disease in the adult oncology population. There are certain therapies that can affect immunity, but in the myeloma setting, I don't think meningococcus is a bad idea if patients have definitely never been vaccinated.
And so you mentioned that this is becoming more of a chronic disease, so patients are living longer with it. So there's going to be lots of things around survivorship that GPs should be talking to their patients about, how they're managing from a mental health perspective, or have they seen their dentist recently, nutrition. So could you speak to some of those issues that we should be talking to our patients about in relation to the fact that this is a disease that they will be hopefully living with for longer and on fairly long-term treatment, but still with this overhanging idea that inevitability is that
That's
it
right.
will relapse?
That's right. This is a side that doesn't often get discussed in detail in specialist consultations. Patients struggle with, I think, the concept of continuous therapy, anxiety about relapse, the need for regular monitoring, and they can become very fixated on the protein level because that's our disease marker that we use. And that can really start to erode their identity, their functional capacity, and their ability to work. So the psychosocial aspects of myeloma care are really critical in supporting patients and helping them to experience the best out of therapy. I will say there's a lot of very good support available through Myeloma Australia, which is Australia's national organisation, not-for-profit organisation that is really dedicated to empowering and educating patients and supporting them on their therapy, as well as family members as well. And they have an excellent website with lots of resources, as well as nurse-led telephone support lines and patient support groups that they hold in person. And so Myeloma Australia is a great resource, and the website is very simple. I think it's going to be in the episode notes, and I think that's a really good place to start. In terms of day-to-day GP consultation, you're time pressured as well. You don't always have the opportunity to do an exhaustive review of patients, but certainly at each visit, checking in with patients, screening for anxiety and depression, offering early referral to psychology or even starting a mental health chronic disease plan is a good start. And also thinking about carer burnout and screening patients' family members, maybe encouraging them to see the GP and talk about what they're experiencing as well. And I think just checking in, supporting patients, letting them know that there is an avenue of support outside of the specialist clinic where patients can go to talk about the stuff that they may not be comfortable talking to the specialist, or they may feel that they don't have time to discuss with the specialist, I think offers a really nice complementary role to the hematologist. In terms of health-related support, I think the things that come up frequently, which GPs may be asked about, is fatigue. And fatigue in myeloma is such a common and multifactorial issue. It's very challenging sometimes to address clearly reversible factors causing fatigue, and we know that a lot of these patients are anemic. They may have been on lots of steroids and experiencing fatigue as a result of that. This in turn leads to sleep disturbance, as well as muscle wasting, myopathy, deconditioning, and reduction in their activity and exercise levels. And then we put the psychological overlay on that as well. And so fatigue really becomes quite a dominant symptom for myeloma patients. How do we address this? Well, it's very difficult. We certainly look for reversible causes like iron and B12 folate deficiency, thyroid dysfunction, sleep apnea is an important one to think about. But if we don't see any correctable medical causes, then one of the best interventions is actually exercise. So paradoxically, the only intervention that's been shown to improve fatigue is exercise and physical activity. And so we're seeing more and more gyms and exercise physiology and physiotherapy practices that are offering programs for patients having cancer treatment. And I think that's a fantastic resource to refer patients to encourage them to engage in a regular physical activity program, which is really the best thing we can do, I think, to help address fatigue.
And I imagine pain for those with sort of lytic bony disease could be a concern. Are there any guidelines that we should be aware of around pain management? What sort of things would you suggest for patients, like starting with the simple things like heat packs or massage, through to avoiding anti-inflammatories, I guess, because of the risk of renal toxicity?
That's right. So pain control is another huge area of need for patients, and it's essential for psychological well-being. So pain in myeloma, if it's due to lytic bone disease or fractures, it's very pervasive and often requires opiate analgesia. And that's difficult because, we're really deprescribing opiates as much as possible in the community. And I think cancer patients have suffered from that trend to get people off, long-term chronic opioid analgesia, which is completely appropriate for a lot of patients. But our patients do need access to effective analgesia, which is often the only agents that will actually address their pain. So we do recommend paracetamol as a foundation, but in general, the non-steroidals we do try to avoid due to that risk of renal toxicity, gastric irritation, and bleeding. Uncontrolled pain is clearly something very serious. And so if patients present with new or worsening pain, we really need to be thinking, is this progression of the myeloma? Do they have a new lytic lesion? Do they have a new fracture? And so early access to imaging, and really CT imaging is the most effective and useful image in that circumstance, is imperative. And then prompt notification of the haematology clinic if you do identify a new fracture or a new lesion, because we do have access to non-pharmacologic methods for analgesia as well, particularly radiotherapy, sometimes surgical fixation, braces, and rarely interventional radiology procedures that can help to stabilize vertebral fractures.
And then I guess we need to be looking for intercurrent infections and treating that promptly, perhaps having a lower threshold for initiating antibiotics than we would otherwise, or referring to hospital for IV antibiotics. Any other suggestions around intercurrent infections?
Yes, so we talked a little bit about vaccination as a way of preventing infection. We do usually have patients on prophylactic antivirals for shingles, prophylactic antibiotics for PJP, but sometimes patients taking prophylaxis will still develop infections, and we do have a low threshold for treating those. Obviously, viral infections are the most common and likely scenario. So respiratory swabs looking for COVID, influenza, these are viral infections that are treatable with medications, and treating bacterial infection with prompt antibiotics is always recommended.
What about when this might be moving towards palliative care? At what stage does that come in? Because I know that patients, once you start mentioning palliative care, they think, oh, it's the end of the road, end of life. But do you tend to involve the teams early to help with things like fatigue, pain management, bowel management, quality of life issues?
Yes, absolutely. In the hospital setting, we're lucky that we have palliative care services readily available, and we often will refer early in patients who are struggling with pain control, patients who are requiring a bit more psychosocial support. and in assistance with advanced care planning. So these are things that, as you say, patients are wary when you suggest a referral to palliative care, and we often have to emphasise that the role of palliative care is not just end-of-life care, but it's symptom control as well. And I think GPs are really ideally positioned to initiate discussions around palliative care, end-of-life care, and planning for what if, because the relationship that you have with your patient often spans many years, and you can touch on these things a little bit more, perhaps a little bit more readily, because there's a rapport, there's a trust there, an existing relationship. So I really value when GPs, advocate for patients and discuss enduring power of attorney, advanced health directives, help patients to identify their goals. What are their priorities? Are they happy with what's happening with their treatment? Do they want to stop treatment? Are there priorities or other goals of treatment that we should be focusing on? So I think in the community setting with the general practitioner, that advanced care planning is really important. And sometimes patients may be initially reluctant to engage in that. They may say, "Look, I'm doing well. I'm on treatment. The doctor tells me my protein's coming down. It's all good." But planning ahead for the future so that things don't take us by surprise is always a good idea.
So we've covered a lot today in terms of talking about like induction chemotherapy, maintenance treatment, the side effects of treatment, vaccinations, ongoing health surveillance. But what we haven't touched on yet is some of the emerging therapies, which are exciting. I wonder if you could just tell us about that briefly.
So we've talked about upfront therapy and maintenance treatment, but inevitably patients will progress and their myeloma will become resistant to treatment and start to cause disease again. And the management of relapse is a really complex topic because we don't have a one-size-fits-all recipe like we do with induction treatment. Relapse treatment is really planned and individualized according to how the disease is behaving, the patient's physical status, the patient's wishes, and logistical factors. And so we've historically cycled through combinations of treatments that, whilst they can be effective, the duration of response typically gets shorter and shorter at each line of therapy, inevitably resulting in end-stage disease where patients can't be salvaged and pass away. In the last, 5 to 10 years, we've had a new class of therapies that are generically referred to as immunotherapies, but more specifically T-cell redirecting therapies. So these are a range of different treatments that effectively use our T-cells, our own T-cells, to recognize and kill myeloma cells. So it's a lot more targeted than our traditional chemotherapy approaches. And there's been a lot of publicity and coverage in the media about CAR T cells, not just in myeloma, but in other blood cancers as well. And CAR T cells are a form of T cell redirecting immunotherapy where we take patients' T cells, genetically modify them to express a receptor that recognizes BCMA on the surface of the myeloma cell. And then we infuse those CAR T cells back into the patient. And once they're infused, the CAR T cells become activated, they expand and proliferate, and they cause T cell mediated killing of the myeloma cells. Another class of agents is the bispecific antibodies, which are antibody drugs that bring together the T cell and the myeloma cell in very close proximity and induce what's called an immune synapse, where the T cell recognizes and becomes activated and kills that myeloma cell directly. And so bispecific antibodies, as opposed to CAR T cells, are given continuously, either weekly, fortnightly, once a month, as long as they're working. But both of those strategies are very effective, have shown very high response rates, particularly in patients with really advanced chemo-refractory disease. And that's why they're so exciting, because they're inducing responses that are deeper and that are lasting longer than any chemotherapy or novel therapy agent that we have access to. So they're really revolutionizing the management of advanced relapse myeloma. And in fact, they're starting to make their way into earlier lines of therapy now, which gives us hope that perhaps in our lifetimes, we may see a cure for myeloma, where with these therapies, we can actually eradicate disease permanently from our patients.
So when you talk about these emerging therapies, T-cell redirecting immune therapies or biospecific antibodies, you've mentioned them in the context of advanced or relapsed myeloma. Do you imagine in your career you'll see a period where they might be introduced as sort of upfront therapy rather than waiting until it's sort of become chemo-resistant and relapsed?
That's the goal, because we think these therapies really rely on having healthy functioning T cells, and by the time we use them in very late relapse, often the T cells are quite exhausted and beaten up by prior lines of therapy. So we are seeing that these agents work even more effectively in earlier lines of treatment. And in fact, we've treated patients on clinical trials already with newly diagnosed myeloma with CAR T cells, and we'll be watching very keenly to see with time how those results pan out, because we are optimistic that we'll see, a proportion of patients who won't need treatment ever again.
Wow. So this is an exciting age then for treatment.
Absolutely.
And for patients. Well, as always, we've covered a lot. I wonder if you have any important takeaway messages for our GP listeners today.
I hope it's been helpful, Rebecca. I know that myeloma is complex, and it feels like there's so many different aspects to touch on, and like any complex disease, you can't cover it all in one consultation. But there's lots of help and resources available, and I'd refer you back to the Myeloma Australia website, which does have some GP resources as well. And I'd also encourage GPs to refer patients to Myeloma Australia, because they're a wealth of information and have so many different information brochures and telephone advice as well. And so at the end of the day, if any questions, I think I said last time, I hope your local haematologist is friendly. Most of the time, very happy to take phone calls if your colleagues have any questions or concerns.
And I'd also like to recommend an article that you sent through to me in preparation for today's podcast and our Part 1 podcast, which was published in Medicine Today in July of 2023, which you wrote with Hayley Beer, entitled Multiple Myeloma in General Practice, A Guide to Diagnosis and Management. It's a fantastic resource. It's got useful tables with vaccination schedules and information about treatment, side effects and toxicity, and survivorship care. So I'd also like to recommend that highly as a fantastic resource for GPs. So Dr. Nicholas Weber, thank you so much for joining me on today's Health Ed podcast and for sharing your expertise and insights. It's a really interesting topic. Not one, myeloma isn't a disease that we may see very often in our career in general practice, but it's certainly something we wouldn't want to miss. We'd need to know when to refer, when to think about it. And it's also important to have an understanding of the treatment options, because when patients come to us, I think it's embarrassing if we don't have at least some understanding of the agents that they might have been commenced on, the toxicities we should be aware of. So it's been very helpful to speak with you. So thank you for your time.
It's a pleasure. Thank you very much.
If you are an Australian healthcare professional and enjoyed listening to this episode, you can claim CPD points by creating a free Health Ed account. Visit healthed.com.au and claim today.